We shall seamlessly move on to the next session, and all the expert panel of the previous session are most welcome to be here because they're absolute the treasures for us to understand more on this very important subject. So after having dealt with the specifics which were looked into in the last session, now we go on to the measurable components, and I'm just breaking the queue and talking first because I have to go for the session.
To invite the expert panel.
Yeah.
So, I'd like to now invite Dr. Devashish Sabeta, sir. Please, Dr. Sudhang Bharti, sir, Dr. Kamal Kapoor, Dr. Mohan Rajan, and Dr. R.D. Ravindran, sir.
Yes.
Sir, please come on the expert panel. So, Chitra Madam will be speaking to us first.
Very good morning to one and all of you. And my due in the next 10 minutes is to tell you all how to empower our employees and retain them in the workforce, because each of you are young people today and tomorrow you're going to have 2, 4, 10. It's going to increase. And there is no point losing your energies by running after newer recruits time and again. So I believe that the basic philosophy is allowing each of these person, of course your recruitment has to be good, you can't bring trash in, but the philosophy once they are inside is to allow them the ability to do independent decisions. Now if your work culture allows you to encourage them that even their mistakes can be, if they have understood their mistake, they can move on, but you're not too reprimanded for that. But having said that, we are in a challenge. This is not a production industry, this is a medical industry where any mistake of yours is going to be so very critical and it's going to be very costly. So we need to have all the controls in the place so that you prevent critical errors from happening. But some minor lapses, you could very gently tell them, and with, unless it can be overlooked also, but give them a very healthy, happy atmosphere to work. You know, when you start as a solo practitioner, you're thinking about the refractionist, the optometrist, the floor assistant, and everything is on your mind. And you have got into the tune of micromanaging. If you want to grow, you have to outgrow this very concept, because then only you will have a better working style. There are capable guys nowadays, 30s and mid 30s, they are so capable of running their own setup. They are coming and working with you because of some kind of a cushioning effect or the thought that they would grow with you. So you need to understand that and not micromanage them. And then if you are empowering your employees, believe me, the whole work culture is going to be very different. We had started off with a 250, 350 square feet area, and if we are what we are, really it could not have happened with me clamoring that I am I Foundation. The sooner you move out of the thought that you only call of I Foundation and not address yourself as what I did so many surgeries, I went to this department, I went to this hospital, I went to that hospital, that's out. All of us are there, all of us, and it should be ingrained in your system that even if you have just 2 doctors with you, it is a we and it is not I at any point of time. And then of course, if you are an intelligent administrator, you would have a monitoring system which should be centralized. It may not be very relevant, this many centers at your stage, but each of you are leaders. The fact that you're sitting in this room is because you want to break these barriers and go out to a different level. So to break that level, you need to be monitoring them in your own disciplined fashion, ensuring that they take their own decisions, but yet they are doing what you are. So for that, you should have multiple review meetings and discussions and open up all your things. Don't keep it all hidden with you. Tomorrow you're buying a microscope, they all need to do. Maybe a microscope is irrelevant. Anything bigger, any bigger move, if you get them all together with you and allow them to hear, not only do they get pride in knowing that the organization in which they are working is growing, but there is some contribution which is coming from them. And don't belittle them and think that they are incapable of contributing. Actually, every single brain is superb and we just need to tap it. And it's our ability to tap it is what makes us a leader and differentiates from the others. So the importance here is making each of your colleagues feel so important. Believe me, there are so many moments of truth which is going to plague them. Preoperatively, the query the patient's going to have, not too happy, you have to make them happy. During surgery, if you have a complication, the nurses are watching, everybody's watching. Post-operative, the vision is not good. So there are so many moments of truth which is anyway going to plague each and every one of us. So each of us have to push ourselves to do our little best. So why do you as a boss need to keep reminding them of that? So there should be different parameters where each of your people assess themselves. And when unknowingly, slowly, the employee feels secured and satisfied, and that is what is the positive work culture. Now, giving them the job satisfaction actually means you're giving them the stability. And I'm telling you, job satisfaction, retention, all is going to just keep ricocheting onto you because they are all one and the same. How do you hold your dear lot together? Because without your knowledge, they would start dreaming your dream with you, and you will not know which is whether it is their dream or your dream. And if it's a common dream, it's the dream because it's a big dream and it's a difficult terrain. There's so much of labor. You might think you own the place, you have money coming in, but they are going to be well paid. There's no second thoughts about it. But there's going to be troughs and peaks, and you need an enormously strong team and a team where they genuinely love for you. When their heart aches when you're getting sick, that kind of involvement is so critical. And that is the core of realization of your dream. If you have retained them all, sky is the limit to what you can reach, because there's not going to be just two hands raised above, there's going to be multiple hands raised to get what you want. Never forget one important thing. Before you recruit a person, you inquire about a person, you check that person, sometimes even look at their surgical skill set, everything. And then when they say at some point of time they have to go, the fault is within you, not just in him. You were not able to retain him. You are not able to get the best of him. So besides losing him, imagine the time wasted in getting him recruited, training him, all those wasted discussions and all those regrets. So sometimes, yes, you would have brought in a very careless person. That's okay. That's a relief in itself. But if you're able to retain them, that would be the best. And giving them job satisfaction is the very primary goal. So we were few of us, and we are as many or lot more than this. It is because I think the only way is if all those mantras are followed, then you have less of your ability to decrease the turnover and keep all of your colleagues working at their best. Now, the next other important point is while they are working with you, giving them n number of surgeries and giving them comfortable working hours and a good room is not enough. Somewhere along the line, they are all intelligent. They may not get the opportunities to grow because you are much older. You are in a different level. But there has to be some growth which is happening. There has to be recognition of them. They should be sure that along with you in their own pace, they will grow. They have maturity, they have wisdom, they have everything when they have joined you. But you have to allow their growth. You cannot be alone doing n number of surgeries. You cannot be alone attending so many meetings. You cannot be holding on to this mic at all places. They should be holding to. We had a live surgery 2-3 months back, and my husband suddenly out of the blue, he said, every time live surgery, it would be Dr. Mahipal Sachdev, it would be Dr. RDR or all Debashish, all top guys. He said, no. We are going to have all our doctors manning different centers. And what he did was wrote without a second, he wrote in the group, how many of you want to do live surgeries? And all of them raised their hands. And I'm giving this talk today, but I was apprehensive. Will they do well? They may be shy. They have not been exposed. No, they were not shy. They were not less exposed. They performed brilliantly, amazingly, because they had treasured that. There was not a complacence. They had not just their dread less. Sometimes some of the seniors, we are a little casual about it. No, they valued that platform which they got, and it was one of the best parts of the program. And that is what is definitely a gratitude and a happiness is inevitable in that. So I'm putting it all rapidly in 10 pearls. So then, as I'd already alluded you to, the best way to gain employee loyalty is to make them feel that you trust them, that they are part of you, they are in this war with you, they are in this best part of it you in all the ways possible. And there would be variations in how they would do the job. It need not be exactly the way you want it. As long as the end result is met, sometimes you will realize that you learned something more. It enhances your vision. But again, you have to communicate to them somehow what is your your clear vision about that place. You believe in integrity. You will not have OCTs used randomly. You will not have them doing FFA. It's not needed. You will not advise cataract surgery for a person not needed. You would not advise clear lens section just because to make money, because your incentives grow up. No, the honesty and what you have, what is your mantra about that place cannot be lost. And if that you could ready to lose that employee of yours if he transgresses that, if that clear vision is across, believe me, they would start respecting you. You should have the ability to have small talks. Look at this, all those reception staff and all those sisters. There's one wonderful girl moving here. She's my room sister, and small little thing there. And she has grown to what she is. It's because I realized there was so much talent in her and kept on noticing her and kept on appreciating her. Sometimes even standing for a group photograph with them or just sharing those photographs with them, they realize you're treating them like human beings. Sometimes you just sisters, are you all lined up? That is not the approach. We are not like Arvind, that they have an excellent HR department and excellent things who are seamlessly doing it. Sometimes we are just there, few of us doing it. So it needs to have a very friendly atmosphere. We have to constantly encourage to make them learn new skills. A new equipment comes, a new surgical device comes. You should put a roster that whoever is connected in the department has an opportunity to meet the technician, learn those skill sets so that they know that along with you they are learning. It shouldn't be that an examiner machine comes, just the top 2 refractive surgeons learn it and other cornea refractive are left behind. No, that's not the way to grow. And you have to be open to ideas. When you have these review meetings, you should be prepared to go in, that you are going to get to hear a lot. You're not just going to be dictating them all the time, because all their opinions are so invaluable. Even if they come with a problem, allow them to solve the problem, come up with their own decisions, and you be sometimes, more often than not, you'll find that those problems are getting solved better. Because I do believe that 2 heads are better than 1. It does inspire creative thinking. It sort of puts a challenge into their hand that they have to do it. And they will do it. There is Dr. Tamil Arsi sitting right behind there. We just told her, take care of the phaco-refractive workshop. I thought I used to do it very well all these years, and I used to look into every tiny thing, but she just floored me the way she did it. So imagine, from now on, I have the humility to understand that she's going to do better than me. So I would keep going back to her. And I'm sure there are so many Tamil Arsis in my place, some best, some next to best, but I have to give that opportunity for them to evolve. These review meetings, you should discuss even basic things like waiting time and what has happened. Why was this patient not happy? Why was the Google review not done? What was the reason? So that they all know that for us to grow along with this organization, all these nitty-gritties have to be seen. Do not hesitate to say thank you. Do not hesitate to say somebody looks pretty. Make them happy. Even if they have made one phone call to a patient and that patient came back, an angry patient came back before them, in a group you have to announce that this doctor of yours did this for a patient. If they have done 10 years of service, 20 years of service, recognize them, give them a certificate, give them the best performer of the month, do everything. Play to their strengths. Do not bring out the negatives of them. Try to talk about all their positives, and then in that gently tell them that this might not have happened. Spend some time, not just they come to your room to tell them what they did. Share a coffee with them, or even take them out for a dinner and talk to them. Tell them what is their potential and how they did this well. Maybe why not they grow in that part of the department and take care of that aspect of it. Those small things have a great impact. I believe that when you learn to delegate problems and not just tasks, your team will grow. Because only a true and a sustainable organization is that which has empowered all its employees. You could be having a bunch of workhorses who do exactly what you want, but that's not what you want. You want those intelligent professionals to have the initiative to use their skill sets to problem solving, innovate, and all of them believe, as in my center, that I Foundation is ours, not us alone. And I'm sure in all of you, in all your setups, if you go back and look at all those faces looking eagerly at you for appreciation and recognition, believe that they have to grow with you. And if you have done that, I promise you, you are going to be winners and going to go to the next level. Thank you very much.
Thank you so much, ma'am. Yes, Dr. Sudhang, sir, you wanted to say?
Yeah, good morning and excellent talk, Chitra, for giving them an idea as to how to retain and how to grow. Another thing which I think is very important is to make them feel that their future is secure with your organization, because majority of times everyone is looking forward to join a government job, because the security of government job is different than the security in a private job. So that kind of security, we
Dr.
have to
Debashish.
spend something like 2 to 5% of our total turnover in the CSR, that is corporate social responsibility. And that corporate social responsibility goes into providing the education and
Yes.
other things to the
Yes.
children of the your employees,
Yes.
to the accommodation. You might be able to provide them a house at a later point in time. Somebody who has worked for 5 years will get some, children's education. For somebody who's worked for 10 years will get additional
Yes.
incentives, and somebody who's worked for 20 years, or is devoted 20-25 years, will get a property. So that's what it is. If you want to retain them for a long time, I think it is very important to look after their requirements, long-term requirements. So, like my organization, I have more than 50% people who are working for more than 20-25 years, only because of the reason that they understand that if they are able to impress upon me that they are doing sincerely, they will be rewarded, positively every time. Yes.
Ravindran sir, just one question. Yeah.
I'll be back within 20 minutes, and I'm going to miss some wonderful talks. Debashish, Dr. Debashish, and Ritika's, but I promise you I will be watching the uh, later recording of it. Thank you.
Yes, ma'am. So, just one question before we move on. There would be once in a while some employees who would probably come up and say, I think I'm being underpaid. I'm doing so much of contribution to your organization. I think I deserve it. And he may truly be a deserving person. And he would say that why not you increase my salary to this? Otherwise, I'll look for other opportunities. So, how would you tackle such situations?
I'll take that, Anga.
Yes.
See, Dr. Bharti said about retention, and Dr. Chitra told that organizational growth is the key thing, because, unless organizational growth happens, how do you create space for, the others to grow in the organization, within the organization? So essentially, today, out of some experience over the last 25 years, we've understood that retention may not be that good an idea, and rather putting systems in place so that we can have a very efficient training system, so that people will come and go, because in this world you can't stop anybody from growing. If they think that our perspectives are not as prospective as they think it to be, they might leave, and you have fresh people coming in. After 1 or 2 years, I think that is the best part of a employee to contribute to the organization. And this is the one thing I wanted to share. And secondly, having systems in place is, you have functions. So more the function an employee knows, maybe he won't be performing that function. But suppose there is absenteeism, there is something else. So if there's 12 function to a OPD job. Now a person knows 12 of them. So he's competent anywhere. He just goes and fills up. And so he becomes a jack of all trades. And we kind of look at leaders around these persons. They may become a center in charge. And so this is the organizational graph that we provide. So essentially, sorry, Dr. Bharti, I know what you understand and you feel so strongly, but I think we have kindly somehow drifted a little away from that.
we don't have time, but the only thing is that sometimes if you have a person who's working for you for 20 years,
Yeah. The best thing is about Dr. Bharti's point is if somebody is 35, working 10 years in your organization, the loyalty factor is very, very high.
Not
Because
loyalty
at
factor,
35,
Devashish.
this guy is not going to get employed anywhere else. So they depend a lot, and from belonging, from dependence comes belonging. I
The
mean, it's
other
very
factor
simple. Let
is
us
that you
understand
can
that.
delegate the work which your headache. You can totally, completely delegate your work to them and be out of it totally.
I think basically the core team, we have to differentiate from the core team versus the peripheral team.
Yeah,
The
yeah.
core team is something who is going to be with you, has been with you, has grown with you. So I think that is something they become sort of indispensable, and then maybe you agree to their demands. But it's the peripheral team, and I think none of you answered
Yeah,
that question. Maybe Dr. Ritika.
in the resilience of the systems, like when we talk about growth and systems to be synergistic, the old people, only thing, you have to really get into them to bring in change, because they are resilient to change a little bit. But yes, I mean, that's okay.
Yes, Doctor.
Excuse me. Hello. इधर चेंज हो गया कुछ. True.
Sir,
Yeah, like coming to your question.
my question.
Yeah,
Yes.
About someone coming and complaining that their salary is not increased. I mean, in a good organization, something like that should not happen. For first thing, somebody should not come and complain to you. Okay, and the way the you have to approach the problem is also like a career growth. So we need to identify people who are really potential. No, they're really doing a good job. I mean, it's always better to have a different scale of pay. You pay, no, you also give them a scale change or a different designation and promote them to a different level, so the people in that same cadre are also not affected. If you keep the person the same cadre, the same scale, and give them an increase compared to others, then it will lead to a lot of dissatisfaction. But changing that person's position, the career, and then giving them a thing is always better. Here again, no, we talked about empowerment. So here within Aravind, it's not decided by the chief medical officer, but by a group of people who will know who under whom they actually work. They decide how much that person is going to do, and it is going to be his headache to manage. If that person is going to leave, and he has to manage the department. So here again, empowering and delegating even the pay rise to the next level is always better. So,
Thank you, sir.
becomes justifiable. And yes,
yeah.
and I mean, I think in this little conversation that we had, that is how growth becomes so important internally also. It's not about the bottom lines and the revenue top lines.
Yes, sir.
Even coming to Dr. Chitra's talking about empowering is very, very important for retention. Not at the level of the doctors, but also the mid-level. The mid-level, if you really empower them, it's not about retention, but better operations. No, empowering the middle level will definitely helps in the operational excellence also.
And growth today may not be simply numerical, because it's very difficult to actually, in many localities, to be numerically growing, but it can grow in content. So I mean, both parts of growth of an organization is as important. If you are not there are limitations to grow in numbers numerically, it is easier task to grow in terms of content. So actually we are today talking, can I start?
Yes, sir. Please, looking
Yeah,
forward to
like
it.
we are talking on measurables, and I have been given the topic target OPD. And let me tell you that OPD is the doorway to the whole hospital. So essentially, OPD is a very important place to understand everything, and that's where things happen. Now, we have an appointment system which gives 5,000 appointments every day across 18 branches, and 20% drop out, 20% are filled in by walk-in patients. So generally, this is the usual story, everyday story, or the history of our hospital. Now, what does an appointment system does vis-a-vis Aravind, which we saw, is it definitely helps in time management, and it helps in on-time service. I think singularly this has become the biggest content of today's service. Nobody has time, so we must be very impromptu in our service timings. So this is one thing. And obviously nobody likes a lot of people waiting. Gives a, waiting times, you have to explain why waiting, keep them occupied so that it feels less, explain them why you are waiting, and occupied waits and all kinds of things you have to treat. Waiting time itself is a managing waiting time is itself a challenge by itself. And of course, if you see a patient quickly, the patient will go to the spectacle outlet, will buy medicines, will go for investigations, or will take the dates. I mean, the other compliance of the follow-up of the consultation will be done properly. So appointment systems, even if you are seeing 5 patients a day, please develop an appointment system for yourself. There are huge systems which function in a different way, but that is their competence. Again, what happens is in appointment systems, if your systems are overloaded, 50% appointments are usually old, 50% are new. So the old patients are generally who would come up, the follow-ups. So they can be scheduled in non-prime times. I mean, a continuous effort can be made in that direction. Like post-op spectacle appointments are important because you get a low-hanging fruit, a spectacle. So, don't overcrowd your spectacle counter by giving, say, a busy surgeon does 20 appointments, surgeries a day, and give it all in one time. So all the 20 just go to the spectacle section and crowd it. So these are little nuances of how to deal with them. And obviously the next follow-ups, the investigation. Suppose the patient's take an injection or there's an OCT review after 1 month. So he does the investigation, then comes to the consultant, which saves time again. So these are little things we've been following. And of course, choosing the second half OPD, OT balancing, these kind of things are required. And evening OPDs we usually keep for high-end, VIPs and some complicated cases who've been referred from or have moved across 10 centers, want something concrete. So at that time, over a cup of tea, we can have a medical board, that kind of a thing. Now, scaling up, I would rather say to people who have come here, with our kind of charges, about 300-400 rupee in the OP, the usual scaling up is till 30 patients. You should confine yourself to your only small clinic. Go to a surgery center, send your patients for diagnostics to some diagnostic center, work with an NGO or with us or any other center, and try to cross that barrier of 30 patients before you really start your proper hospital chamber. Because without these critical numbers, it doesn't kind of work in financial calculations. I'll come to that later. And then you go ahead. If you're growing, suppose you are 25 patients, but you're growing at 20%. So the next year you are 30 patients. So, I mean, these things you have to take into account. And between 30 to 70 is a wonderful number where you can, if you're having them on a regular basis, you can definitely plan your own setup. And between now it becomes a multiplication, and sometimes there'll be economies of scale, sometimes there'll be diseconomies, because suppose something between 90 patients will be a diseconomy, but 60-70 will be a very good economy of scale. So Now here, when you have 150 patients, today that the entire concept's becoming hyper local, people want it closer to home. Whether you should have a second center or a higher center, or you want a replication of the first center, is something that you need to trade off. So that's what I'm saying, that with 250 patients, you can have a VROT, and above 400, it is a 9-doctor. So essentially, it's a 50 patients a day. If the doctor is seeing at the end of the year, if he's seeing around 15,000 patients, I think that is a good target OPD for a good consultant work. I'm not saying about fellows or trainees. Now, this is a OPD cost is a place where most institutions lose money. You know, to get one cataract, you would understand you will spend 3,500 rupees just to get a cataract surgery. In subsidization, almost every OPD is subsidized except Ritika's OPD. And subsidized to the tune of, say, 300-400 rupees. So 15 patients, you eventually end up spending 3,500 rupees in the OPD to get a cataract. So that is a preliminary cost for cataract. Please add to your cataract cost, Ritika, because that's what you are going to speak on. So this is a primary cost. If we were talking, having a discussion on the camps, I think the same formulas also apply to camps. Yes, sorry.
Last slide, why is not changing? The doctor's cost.
The doctor's cost. No, I mean, the doctor is, it's 150 rupees per patient. So essentially, that's what not changing. The variable cost and the other costs will be divided by economies of scale. So, this is, we have a culture in our Disha that a macula is best seen by a OCT. So our OCT numbers, and we do it for 300 rupees. Now, if your OPD cost is low, just understand what does a patient spend in the OPD. He is comfortable spending a 1 day's income, 1 day's per capita is a comfortable spend. It could be in South Delhi, it could be 10,000 rupees. In our situation, it is 700 rupees. So that is what he is comfortable. So if you have 200 rupees, you add a OCT, or you add some medicines, you add a spectacle. So all that fits into his spend, and he is comfortable. So OPD, our numbers are every 10th patient gets an OCT. So, I mean, if you are seeing 150 patients, there are 15 OCTs. So that's how you recover the costs. ASP and DFP, I'll tell you what, give a photograph of a BRVO or even a cataract and say, this is the cataract. The patient's been going to 10 doctors. I can see everything. Everybody's saying, I need an operation. Now, humko photo de diya cataract wala. So that is more convincing. So use these devising tools. And if you keep what I'm trying to say is keep the basic consultations low and fit in these investigations. Ultimately, the patients get more satisfaction, and you also get these services, and you are more authentic in your delivery. So these are the list of other things. We do Optos. We use Optos in a center of 300, and we use it as an indirect ophthalmoscope. So this is the Optos thing at 300, and the calculations are 500 patients, 50 patients per day. You get at least 10% myopics. So all myopics go to Optos, 250 days, 300 rupees, and 38 lakh yearly recovery. So, I mean, You can even increase it to 600, so you just need 250 patients. Now, I will not go into OPD costs because that is Ritika's area. But what I'm trying to say is, unless you are seeing 30 patients, when you are seeing, the number of cataracts that you would expect is 400 a year. And the surgical cost of the center would be, if you take the lens, 2,500 will be 11,000 rupees. Whereas in 8,000 rupees, you get good surgery centers to operate for. So why would you spend it? Doesn't become that. So at 50 patients, probably, you hit that bullseye, and you should be investing in a surgery center. So sorry, I mean, that was Ritika's past. This is again the same thing, so I'll skip that. Now, going into the doctors, how do we actually compensate for us? Like, say, Aditya Bajaj has a compliance ratio of 78%. What I'm trying to say is, somebody may be sprinkling cataract advices, so his compliance will be low. And somebody who is talking to the patients and really getting into him will probably advise 60 surgeries, and 40 of them will convert. So he has a better compliance ratio, and we compensate that. We talk to them also, and we compensate that. So that waiting time also, we for consultants, because it is big money, everything is titrated. Intervention ratio, brand, waiting time, number of patients, number of surgeries, spectacle conversions, medicines you prescribe, everything. So because I'll explain brand later. So this is how, if you are red, you get only 50% of the 150 or 200 rupees. If you are green, you get 100%. So that is it is 30 minutes, 45 minutes, 1 hour. So this is how we manage things. And of course, these systems help in automated, targeted giving out to their WhatsApp or to their emails specific information which help in second eye conversions or in lasers and injections, and reminder follow-ups calling for second eyes. Now explain you about the branding thing. Now, when we give appointments, we ask, do you want a specific doctor, or you have a problem? What is your problem? Do you have a specific doctor in mind? Says yes. So it becomes a brand for that doctor. Now, we communicate that with the doctor. After 5 years, the doctor is given a choice whether he wants to be a brand doctor or whether he wants to be a general pool Disha doctor. Now, when he becomes a brand doctor, he gets 30% more, but he doesn't get Disha patients. So he can work more, work less, earn more. So that's the little things, nuances that I had to share in this 10 minutes. Thank you.
Excellent, sir. Absolutely mind-boggling. I think I have no words. You have covered absolutely everything. I wish we could have, on each slide, we could have had a complete 10 minutes on each slide rather than the entire talk on 10 minutes. Dr. Ravindran, sir, your comments on that.
No, I was just telling him his talks are always unique. You made a great presentation, and there is a lot I'm going to ask him after the talk.
So one question before Dr. Ritika can please come. So regarding the appointment, you said you'll give 5,000 appointments in a day. Like you said, even if you have 5 OPD patients a day, you give appointment. For 5 OPD patients, is easier. If you have an OPD of say 200 or 300, then don't you think each patient who has been given an appointment?
Telephone appointments would be around 60%. Huh? 2,000. Huh?
3,000.
So
And
my question
the
is,
rest of the patients, when they go, the second appointments, like the 50% would be follow-up appointments. So they take some, the family members come to show somebody else's eyes. They take somebody else's appointment. So in-person appointments are about 40.
so the question I had was, many times
Have
when
a
an
manpower
appointment is
planning.
given at say 10 a.m., the patient usually turns up at 10:15, and then the next appointment gets delayed.
No,
Plus,
we have the other problem. They usually come much before. It depends like how much distance they travel.
but don't they, because once they
For
get
our
dilated,
centers, usually they travel 20 to 30 kilometers to avail our service.
so the expectations of patients are they need to be checked at the time that they have been given appointment. So for example, if there has been some patient waiting before that, or there have been walk-ins whom you obviously you will not
You know,
send back.
yeah, in a center there is a culture, so they know what exactly is the culture of the place. Because most of the place patients are recruited word of mouth. It is that they don't want to waste time in the hospital. I mean, they feel that it's a waste of time, especially the person accompanying the patient.
Yes.
Patient is an old man or an old lady, fine with her, but the person bringing him, he doesn't have time. Shreyash doesn't have time.
So to keep up the appointment sometimes becomes difficult, especially if they have to do OCTs and dilatation and repeated consultations.
I mean,
So the more time they
we need to
spend,
plan all of that,
all of that. Yes.
and that is where multiple functions, knowing multiple functions for staff, etc., etc. The more flexible we are in the delivery system, better it is.
So
One way to address your thing is, if you can get additional information about the patient, about the age, systemic status, whatever investigation they have done earlier or consultation they had. If all of that they are able to upload into your system, then you can also allocate the time accordingly.
right,
Yeah.
that's a good idea. Thank you so much, sir. So I'd like to now invite Dr. Ritika Sachdev. She's an excellent surgeon, but I think more excellent administrator and lots to learn from you. Looking forward to your talk.
Thank you. I'll just be talking about the IPD because it is a large portion of our revenue, and the OPD effectively converges to the IPD. And like Sir said, every business works on a customer acquisition cost. And for us, eventually, the patient acquisition cost is the sum total of the sourcing, that is the marketing, plus the OPD cost that has gone into the patient. So I won't be talking about the OPD. I'll basically be sharing the IPD metrics. This is actually something that my team has prepared, so it's really what they do track. So first, I think we should all tell ourselves that it is very important to watch and have numbers, because what you don't watch, you don't monitor, you cannot address, and you can't make better. So you must, in the context of knowing the present, know the past. What was your last month, last year? And also try and predict your business. It is a very exciting thing that you should try and set a benchmark or a forecast and then look back at those numbers. So I'll just come to the IPD, sales, as well as the operations metrics that we target. For the sales team, it is their duty to get in more IPD patients. So we tell them to map channel-wise or service-wise. That basically means they should know where more IPD is coming from. For example, they may be focusing on one demography which is not giving useful patients. Maybe they don't trust the brand. Maybe they're not okay with the price. So wherever the patient who is converting is your TG, which is your target group, because not everybody associates with your brand. Then you have the percentage of patients that the sales team is getting. How many of them are being advised a particular service? For example, if you have a purely cataract center and the sales team is getting you patients who are less than 50 years, it is not your target group. However, if you have a refractive center, you have to focus on the 18 to 35 group also. So have the addressable audience being mapped and being validated that the sales team is making efforts in the right direction. Now we come to the operational profiling. You must capture data through multiple sources, HIS being the most authentic. A lot of doctors don't use the HIS, so get a lot of information from billing, especially for IPD, because billing is usually sacrosanct. We also have an OT register, a feedback mechanism, and we have review meetings. So this is the operational indicators that we map. First is that whenever a patient walks into the OPD, we tag the patient. A surgical patient has to be tagged because that is your maximum revenue patient. Once the patient is advised a surgery, only then he goes to the counselor and a tracker into the form of a counselor tracker is made. Counseling is same as compliance. That means if somebody has been advised a cataract surgery, is he choosing to get it done at your center? The counselor post the doctor makes a list of the patients advised and done. You should also have a cash credit mix. Sometimes credit patients convert easily in larger centers because they are not worried about the price they have to pay. So map your conversion for cash and credit separately. We also have a follow-up call done for patients either who don't convert or who decide to get the surgery done at a later time. Now, once a patient does decide to get surgery, this patient should be your brand ambassador, right? So then we do an NPS scoring. I'll talk more about it. We also break down each surgery which is done in terms of the service and the price that the patient is willing to pay. And then, of course, comes the clinical outcome measurement, which comes in terms of the UCVA, BCVA achieved, and the spherical equivalent and cylindrical power that the patient is left with. So coming to prioritizing the surgical patient, can be done in a software. I'm showing you the printout version of it. Each patient is given a sticker. We have a green sticker for cataract and a pink sticker for refractive, because these are the two most impatient patients. They can shop around. A retina patient is less likely to shop around because they come for specialty and a larger footprint hospital, retina and glaucoma specifically. So cataract and refractive definitely should be prioritized. The whole system should be wired to know this is a cataract patient or a refractive patient. In a large OPD, sometimes that does not happen, but ideally you should have multiple touch points. This sticker can be put by anybody, right from the front office to the optometrist, whoever realizes first that this is a surgical patient. Now, like I said, once you do the counseling, the counseling conversion, a benchmark is set. It is tracked doctor-wise and counselor-wise. So if a particular doctor or a particular counselor is having a better or a worse performance, you will be able to have a trend. We do expect a benchmark of greater than 60% in a center which is moderately aged. In greater age centers, larger centers, the conversion is much higher, can be up to 90% also, right? Now, once a counselor you may have lost patients, right? It's very important to know that you have done the patient, but what happens when you lose the patient? So you ask the counselor to note down the reason for not choosing us. You can also have a follow-up call, and sometimes there is a mix of junior or senior doctors. Offer the patient a repeat, even a teleconsult, or another opinion with a senior doctor of your center, right? And always centralize a random sample, in the sense that don't depend on the center to make all the follow-up calls. Centralize some of them so that you are able to have an independent audit of the performance of the counselor or the doctor. So just do a random sampling. And second eye will always remain as a follow-up till it is done. We also, for the counselor and doctor, being able to follow protocols properly, also look at the same day rescheduling of the surgery. Because if the patient is being rescheduled multiple times because of TPA processing or blood sugar, these are operational issues that you will have to address, because they allow your planning to really not be proper. Because if you have allocated time in the OT and the patient is being rescheduled repeatedly, you have to have some addressable measures. So I'll just now move back to what happens when the surgery is done or not done. When the surgery is done, we should get a feedback from a large sample of our surgical patients. What we calculate is the net promoter score. A net promoter score is a metric that is used across industries, which basically means how likely is your patient to promote you, right? Talk about you and send other patients to you. It stems from one single question: how likely are you to send your friends and relatives to us? This is calculated on an 11-point scale, going from 0 up to 10. Okay, so if somebody says 9 or 10, they are your promoters. If they say 0 to 6, they are your detractors. That means they will actually talk ill about you. 7, 8, 9 are your passives. They will get 6, 7, 8 are your passives. So they will not talk about you. So your net promoter score is promoters minus detractors, because a negative voice is going to do a harmful impact. So ideally, a net promoter score above 50 is considered good, but our benchmark, which is the ideal benchmark in the service industry, is 72. So that is something we aspire for, and we rank all our centers as per the NPS to set up a competition grid for all of them. Now comes the pricing. It is very important that you see if your pricing is causing a problem in conversion. So you should ask the patient, why are you not getting done? We sometimes allow a 10% discount at the center level because there may be intense competition, and we normally price ourselves 10% higher than the market as a pricing position. So in order to become competitive with the market, there may be some leeway of discount, but you will have to calculate this over a period of time. I've already spoken about this. This is the doctor-wise mapping. It is important not only to calculate the conversion of a doctor, but also the ATV, or the average ticket value of a doctor. For example, a doctor may be converting to a lower package very easily. If a doctor is trying to move up, trying to sell more of the femto or a trifocal, his conversion may initially go down, but his revenue is going to go up. And you can play on volume, but you can also play on value. So value is a good proposition, and so is volume, but you should track both. So this is the ATV of a doctor. And so our ATV varies very widely across the group. It can be 70,000 for a cataract and 17,000, depending on the place that we are doing the surgery. We also look at the IOL. You should know the IOLs that are being consumed, because you may have some bundling with the company, or you may have better gross margins with certain IOLs. So after this, I basically would want to come to a point. It is, I think, some sort of learning from mistakes. We always look at the center's revenue and the center's total surgery, but we must look at the product mix. This learning came to me from, we hire some people who are not from the hospital industry. So one of the persons we hired, he said that we don't even launch 3 phones similarly. So every product is marketed separately across groups. For example, in Samsung, you have a fridge market separately, a phone market separately, and a television market separately, and each of the verticals has to reach the target. So we have a product mix, in the sense, if cataract conversion is good but refractive is low, you have a different investment for refractive. So track each product, each conversion separately. The cataract separately, the refractive separately, the retina separately, the glaucoma separately. And always have a trend line for each. Right? And volume value is what I had said. Know your gross margins, because only if you know your gross margins do you know what is the volume you need to get and what is the discounting you can do. For new products and services, this is something that we did when we launched a new product, for example, Smile and Femto. Train the people about the new product, set targets, but gamify the whole thing for them. Because a lot of what we say is abstract, just like a lecture is, but if you gamify it and give them like a scorecard or a campaign. For example, we had a Femto 100 campaign when we wanted to hit 100 Femto numbers. Now we may be doing much higher, but it just creates a scorecard for the entire team that you can look at every day. And gamification is like, that's how children get addicted to video games. Getting a scorecard is like a dopamine kick, right? Every time you see the scorecard going up or meeting a target. So that is the gamification you can do for new product lines and services. The final thing that we must monitor as doctors is, of course, the adverse event or the complication rate. Like I said, not all doctors document their adverse event. So we take billing as an indicator. Any procedure that has to be redone in the OT is done free of cost, but a billing of 0 is done. That is a redo billing. So anybody who requires another intervention will be mapped. So this is the adverse event. And then, of course, we have anesthesia adverse events. We have visual acuity better than 612, or we divide patients into those with a guarded visual prognosis and not guarded visual prognosis. And this is can be in tune with your NABH indicators. Post-op spherical refraction, which is an indicator of your biometry, is an optometry kind of an audit. So I just like to end with the top tips. Prioritize your surgical patients. Always have different criteria for different service verticals, be it cataract, be it refractive, and the others. Do have outcomes and benchmarks. But what is most important is to automate your data points and to plot them over time to discover the trends. Goal setting really is the first step for turning the invisible into the visible. But always remember, do not cut paste somebody's strategy to your own. For example, volume or value, you have to find out what mix works for you. Refractive or cataract, city specific pricing. So you cannot cut paste or copy anybody's strategy. Think long term, never undercut your brand or your vision. Identify the gaps of reasons of non-conversion or unhappy patients and address them, be it in IT, HR, or equipment. Thank you for your attention.
A question to wonderful talk, superb talk. She's one of your age group. So if she can do it, I'm sure all of you can do it or already are doing it. So just this question to Dr. Debashish or Dr. Mahipal, both of you. And now when a young person is going to start a practice in a particular place, does he price his charges based on the surrounding practice, or does he start it lower? But then if you start it lower, it gets difficult to raise the pricing. So what would you advise this young audience?
You got that very wrong, Chitra. You can raise your charges, but you can't bring down your charges.
No. I'm just asked a question. I did not say about my thing. These young people who are starting their practice.
We are minimalistic and frugalistic persons. Mahipal will have a different answer. I think for a youngster, it's better that, pricing is not a shadow pricing. We don't believe in shadow pricing. Chitra charges this, so I must charge. Otherwise, I'm less competent than Chitra. Is something, a logic we don't buy. You have to get the numbers right. You have to get your, like Kritika gave a lot of matrices.
Yes.
You get the matrix right. And then you decide on a pricing. But if you say, should I underprice or be more towards the fair side of pricing, or are we going for a number thing, or are we going for a revenue thing or a bottom line thing? If you are planning a number thing to take care of your future, I think that is a better way, because as I said, that growth is so essential in an organization. So if you a little underpriced, and in Disha we found that if you surprise your patients with good quality and a very fair price or a low price, the acceptance is wonderful. It could happen other ways, but it's a better way to get numbers for beginners, I would say.
Yeah, thank you so much, sir. Excellent
Just
talk,
wanted
Dr.
to add a
Ritika.
point that we do
Yeah.
pricing. You're not the leader when you're entering a market.
Yes.
So you actually have to look at the leader.
Yes.
So like in Kolkata, our prices are lower than in Delhi, much lower, because we cannot dictate Kolkata.
That's exactly what I wanted.
Always look at the
No,
leader.
see,
You gave a moral lecture. She's telling practical points.
No, I'm telling. No, I am always willing to, share things. It is what is, now let us come to pricing. What is a comfortable spend for a cataract surgery? I think everybody will agree 1 month's GDP or 1 month's per capita. So if it is 80,000 in South Delhi, it is 20,000 in our districts and 30,000 in the town. So that is our pricing. So, I mean, please have that pricing structure in mind.
Yeah,
I
Dr.
think
Ritika.
Dr. RDR can also give some. No, pricing is very, very critical.
Yes, very critical.
I agree.
Absolutely critical.
Yes.
Not out of the
But you have a lot of IOLs to price your cataract in a range. The other important factor is that if you're starting your practice and looking for insurance, your cash prices also determine the insurance rates that you get. So practically, please keep that into account.
Yes. Thank you very much.
Regarding
I'm
the
lucky I
targets-
heard a bit of your talk.
Just one question, Dr. Ritika. Regarding the targets that you mentioned, every year, how much, by what percentage do you increase the targets? And what are the factors, quickly, if you can?
If we increase by some, he increases by more.
Okay, we'll go on to our next session. Thank you very
No,
much.
Ritika, one question.
Yes, sir.
You measured a lot of things.
Yes, sir.
How do we reward these things?
Sir, in terms of
I spoke to you about rewarding, no, doctor? I spoke in the first talk how you have to reward.
No. I want the measurables.
Measurables.
the
Okay.
measurables in terms of the
Like if you do 20% more, what do you get?
Yes, exactly.
Sir, so we have an incentive plan. If per center, mostly we treat them as a group. So if they reach together, they get more. If we feel that sometimes we have campaigns, for example, in the peak months, we may do individual incentives per counselors, and the doctors also have some incentive plans. So they are given the scorecard. Eventually, what happens is doctors may not be only motivated by the incentive. We give them a relative conversion of other doctors of the same center because they are getting the same patient mix. So we don't, and in ATV, every doctor knows their ATV, and the incentive is different for the premium procedures. So therefore, there is an incentive to upgrade, there is an incentive to do more also, and there is an incentive as a team also. So that is.
Yes, thank you. Beyond that, you have to have a separate counseling session with our Dr.